for having me. I will briefly talk to you about the current recommendation for treatment of convulsive status epilepticus. As you know, status epilepticus is a true neurological emergency with very high morbidity and mortality. It not only can cause neuronal damage and affect the future neurological function, but it quickly can turn into a systemic insult and cause circulatory collapse and respiratory depression, severe acidosis, shrapnel, cardiac depression, and it can be a true challenge to save these patients. As time passes, the morbidity and mortality increases, and at the same time, the chance of resistant to treatment increases. We actually have good evidence that the longer you wait, or the more the diagnosis is delayed, the chance of resistant to treatment will increase. So what do we, in terms of definition, what is the status epilepticus? If you have persistent seizure or periods of intermittent seizure without the patient getting back to normal baseline mental status, that's status epilepticus. However, there has been a lot of controversy about the duration of the persistent seizure. How long a patient should be seizing for you to call it status epilepticus? In the past, it was 30 minutes, which really doesn't make sense because we're talking about neuronal death and a lot of risk, mortality, morbidity, but you shouldn't be waiting 30 minutes to label the patient status epilepticus. So recent guidelines have reduced that to 10 minutes or 5 minutes, but the reality is if you have a patient that's seizing more than a few minutes and you're getting a sense that the seizure is not stopping, you should blow the minds, gather your team, and start treating the patient aggressively for status epilepticus. So this is a kind of diagram for treatment that I created. If you look at some of the guidelines, you will see that there is a step 1, step 2, step 3, things that you have to do. In reality, the correct thing to do is that you have to do all the things on the top at the same time. It has to be simultaneous teamwork. You have to stabilize the patient, obviously. This is something that we're all good at. You need to suction the airway with a nasal trumpet or oral airway, put the patient on oxygen, get your IV, start your IV fluids, put the patient on the monitor, get finger sticks and your electrolytes. While you're doing that, you have to think about the etiology. You have to gather information about the etiology. Why is that up there in the treatment algorithm? Because more than 2/3 of the patients with status epilepticus have no history of epilepsy. So there is a very good chance that your patient has some etiology that needs to be addressed different from epilepsy. If someone is seizing from hyponatremia or hypoglycemia, it doesn't matter how much benzodiazepine you give them, they might not stop seizing. If someone has INH toxicity, you need to know that in order to be able to treat. At the same time, while you're doing those two, you have to start, you give a fast-acting anticonvulsant to stop the seizure. And again, at the same time, order your second-line, longer-acting anticonvulsant to prevent the recurrence of seizure. So this is a clear case of multitasking, which we're all good at. But you need, my suggestion is to have a team leader who stands at the bedside, doesn't touch the patient, but guides everyone to do different things. Because you need to look over a bunch of different things. You need to do a lot of things at the same time. So you need a team leader that can oversee all of those. On a side note, I always bragged about being in emergency medicine and mastered the art of multitasking, as we all do. But then a few years ago, my wife and I had twins, And that was a humbling experience. So now every time I am faced with a task that requires multitasking, the first question that comes to my mind is, how would my wife manage this? And going back to the treatment algorithm, so again, the top 4, they have to happen very quickly and simultaneously. You give your benzodiazepine to stop the seizure immediately. You give your second line longer-acting anticonvulsives, and then you have 10-15 minutes to wash the patient. You can repeat your benzodiazepine. You can repeat your second-line treatment while you're waiting. But when you hit that 30 minutes to 40-minute mark, if your patient is still seizing, this is what we call refractory status of epilepticus. Then you have to intubate the patient and put the patient into drug coma. And that's what we're going to talk about briefly. So, Diazepam or Lorazepam. This is actually the only part of my lecture that is based on solid evidence. The rest of it is... Anyway, so some people like Diazepam because it's highly fat soluble. It gets through the blood-brain barrier very quickly. In a matter of few seconds, it stops the seizure. But then it has very high volume of distribution, so it disappears from the system quickly. And if you give it, if it's the only anticonvulsant that you're giving to the patient, there's a very high chance that the patient might seize it. But this doesn't matter, right? Because we are giving a longer-acting anticonvulsant at the same time, right? Some people like Lorazepam. It is less fat soluble. It takes it a minute or two to get to the brain and stop the seizure, but it stays in the system for longer, so the chance of recurrence of seizure is less. Again, that doesn't matter. You're giving benzodiazepines and longer-acting anticonvulsants at the same time. You also have the option of midazolam, right? We have a good evidence from Rampart study that midazolam IM works beautifully to stop the seizure. And then you have diazepam as a rectal gel, you have midazolam as a nasal, buccal. You have many other ways to do this. So my take on this is, just find an orifice and give your benzodiazepine. Just pick one, give your benzodiazepine, and move on. So this, the standard 1 milligram, 2 milligram Ativan that we give to the patients is really not adequate. You have to give the right dose of Ativan. The right dose of Ativan is 0.1 milligram per kilogram. You can divide it into 2 doses, or just find, give 4 milligram slow IV push. Give it a few minutes. If it doesn't work, give another 4 milligram. Best to order the 8 milligram. Give the 4, have it in your pocket, so you don't have to ask your nurse to run to the medication room, and then give the other 4. For diazepam, the dose is 0.2 milligram per kg. So in Brooklyn, our minimum dose is 20 to 30 milligram of diazepam in 2 doses. But you can repeat the dose every 5 to 10 minutes. What is the maximum dose for lorazepam and diazepam? Anybody knows? There is no maximum dose. So these are actually pretty safe medications. You can repeat the Ativan and diazepam as many times as you want. However, you have to keep in mind that if you give this minimum dose and the seizure is not stopped, then you're probably dealing with benzodiazepine-resistant status epilepticus, something we call established status epilepticus. So this is, as I said, this is based on the evidence. The other cases of, the other reason, non-epilepsy causes of status epilepticus, you can see there are many different etiologies, and sometimes you need to identify this reason in order to successfully treat the status. Going back to the correlation of time to treatment with resistant to treatment, as time passes, it will be harder to stop the status epilepticus, and of course your mortality and morbidity will significantly increase. Here's when we get to the second line anticonvulsants. Here's where the evidence base gets very hazy. We have 3 different types of second-line agents. Most of us are familiar with phosphonate, we feel comfortable using it. There are some small studies recently showed that maybe valproic acid is a better choice. We don't know really. And some neurologists like to use Diazepam, especially for focal status epilepticus. But the truth is we don't have any trial that has compared these 3 head-to-head. We don't know which one is more effective or which one is safer. That's why we're all, that's why we're doing the ESET trial, established status epilepticus trial, which actually doing exactly this. The patients who are resistant to benzodiazepines are going to be randomized to one of these 3, and hopefully in a year or 2, you'll have solid evidence to know which one of these medications are more effective and which one are more safe. When we get to that 30 minutes, 40 minutes mark and the patient is still seizing, that's what we call refractory status. At this point, we have to intubate the patient and put the patient on high-dose midazolam drip, propofol, or pentobarbital for no good reason. No, actually, the reason is you want to protect the brain, but it's really, we don't have any evidence that this actually does anything, saves lives or not. And these medications, this is what they do. They cause this burst suppression, which is supposed to be neuroprotective. So on the EEG, you see this periods of high voltage and slow activity followed by standstill. That's kind of asystole of the brain. So these medications calm down the brain, put it in a standstill until hopefully some other medications that we have given kick in and fix the problem. This is a totally non-evidence-based, strictly personal opinion that I believe we, as emergency physicians, don't like the idea of having a patient who is altered and is seizing on benzodiazepine, not intubated, right? So I believe we pull our guns too fast and we intubate a lot of these patients. But in this particular case, there's no right or wrong here, but in this particular case, for convulsive status epilepticus, I want to encourage you to delay the intubation as much as we can. Hear me out. First of all, there was a really good study in the 90s that they compared Diazepam to Lorazepam to placebo for status epilepticus, and actually the rate of respiratory depression was much higher in the placebo group. That means that it's really the status epilepticus that causes the respiratory depression and not necessarily the benzodiazepines. For benzodiazepine to cause respiratory depression, you really have to give very high dose. So it's pretty safe to give large doses of benzodiazepine and just watch the patient. Most of the time, if you suction the patient with a nasal trumpet, put them on O2, nasal oxygen or non-rebreather mask, most of the patients do well and they maintain their airway. Of course, if the patient is vomiting or they have ICH or you you're putting them on propofol, then you intubate. But best to delay this as much as you can so you don't lose that motor activity that is your only guide of treatment, whether your treatment is working or not. Most of us don't have EEG monitoring in EEG, correct? So if you don't have EEG monitoring in EEG, you want that motor activity to be present so you can guide your treatment. But if you have to intubate, you have to intubate. And in that case, just don't use long-acting paralytics and order your EEG monitor. Excuse me. Why does treatment fail? One issue, as I mentioned, that you don't, if you don't identify that the patient is seizing because of, tricyclic overdose or infection or something like that, then you're not going to be able to stop the status. Other reason is duration of seizure. If the seizure has been going on for a long time, it is much, much harder to treat the status. And then the third reason is inadequate dosage of medication. Which one do you think is the most common? So, again, that 1 or 2 milligrams of Ativan that we give and we wait, we park the patient, call neurology for the last, that delays the treatment. That's not an adequate dose. It delays the treatment, and as you delay the treatment, it will become much, much harder to treat the patient. So please order an adequate dose of benzodiazepine. So your patient was seizing, you gave all this medication, and now convulsions stopped. You go about doing your business and seeing other patients, and now it's 20 minutes, 30 minutes, and the patient is still altered, or you cannot wake them up. This is most likely now a non-convulsive seizure. It happens quite often, but 20 to 25% of patients go from the status epilepticus, convulsive status epilepticus to non-convulsive status epilepticus. And sometimes patients present with non-convulsive status epilepticus. That means you just have an altered patient that has no clinical manifestation of seizure and their brain is being fried. So you have to keep an eye on this. Actually, Kaplan in Johns Hopkins, they did a study and they reported that 50% of non-convulsive seizures were diagnosed more than 24 hours after presentation to the EP. One common reason is that most of us don't have EEG available to us in the EP. And probably our index of suspicion is not that high, but it's something that you have to think about. In my opinion, let's see if this one works. So if you have a convulsive status epilepticus and it goes into non-convulsive status epilepticus, that's when things go from bad to worse. Because A, you again lose that motor activity that was guiding your treatment. Now you have no idea what is happening. Again, assume that you don't have EEG monitoring. And B, if you think the evidence was weak about treating convulsive seizure, wait until you hear treatment guidelines for non-convulsive seizure. Actually, there is no evidence. We don't know how to treat these non-convulsive seizures. The few poorly done studies on treatment of non-convulsive seizures are done on ICU patients. So in my opinion, if non-convulsive seizure lasts that long, until a day later or hours later, until the patient is in the ICU, and someone orders an EEG, and then it takes 6-7 hours for someone to look at the EEG, if that patient still has non-convulsive seizure after that time, you're dealing with a completely different animal. So if you don't know how to treat, then what's the best way to treat non-convulsive seizure in the emergency room? I don't know if you're familiar with this device. This is called micro-EEG. It was made by Signal. I have no financial ties to this company, but I've used it in my studies in the past. It's, as far as I know, it's the only portable, only FDA-approved portable EEG device. It's wireless, it's portable, and it's really easy to administer into started, you don't need to get an EEG technician to do this, and it wirelessly sends the EEG through a server that neurologists at home or anyone else can look at the EEG and call them back with the results. Hopefully, this will be available to us in the near future. Quickly, we did 2 studies in our shop on this topic. The first one was we enrolled about 300 patients who were altered with EEG, and we got EEG on all of them to estimate the prevalence of non-convulsive seizure. And 5% of the patients had non-convulsive seizure. Half of those were non-convulsive status epilepticus. So 5% of altered patients in your ED are likely to have non-convulsive seizure, and most of them are missed. That was a relatively scary number. And then we did another randomized control trial. We randomized altered patients to micro-EEG versus no micro-EEG to see how that affects the clinical management. And again, in the arm that patients received EEG, again, 5% of them had non-convulsive seizure. So that kind of proves that this 5% is probably the right number. Just a couple of numbers to remember. The mortality for the non-convulsive seizure is approximately 17%, but the mortality significantly increases if you have an underlying pathology like stroke or intracranial hemorrhage. 30% of the patients that receive the status epilepticus have history of epilepsy. 30% status epilepticus is the presentation of the first presentation of epilepsy, and 30% are from other reasons. And 20% of convulsive status epilepticus they usually go into non-convulsive status. And roughly 40% of convulsive status epilepticus are benzodiazepine resistant. And this is what I want you to keep in mind, that 5% of patients with altered patients have non-convulsive seizure. Just, I want to emphasize on a couple of things. Make sure that you give the right dose of medication. Think about don't be afraid of benzodiazepines. You can give high doses. Focus on stopping the status. That will prevent the circulatory shock and respiratory depression. Give the right dose. And watch out for non-convulsive status epilepticus. Thank you.